It's been said that history repeats itself. But in order to avoid problems repeating bad history, you need to know history. Because if you don't know what didn't work, you might try it and find out that you shouldn't have done what you did. So, let's start from the beginning. There was nothing. And then there was a big bang. And the earth was born. And then the humans arrived. In the beginning, they weren't worried about the vagina as much as they were not being eaten alive by the predators. And then, 2,000 years ago, they became civilized. And a Greek, Cyrannus, who was living in Ephesus, just like Dr. Bader is not living in Greece anymore, this guy was living somewhere else, decided that he and his strong surgical assistants were going to conduct the first labiaplasty in recorded history. Because the woman had protrusion. And they decided that this protrusion made the woman look too manly to their liking. So the good assistants held the woman down, no anesthesia, and they put a clamp around the protruding tissue, they cut it off, and they took a hot knife from the fire, and they cauterized. So that was the first energy-based device. That was the first labiaplasty procedure. Of course, it wasn't very popular with the ladies, and that's how it went through history in the beginning. Episodic cases. 30 years ago, Dr. David Matlock, a gynecologist, just like you, but not like you, had a patient with a cystocele and a rectocele, gynecologic issues, and he did an anterior and a posterior repair. And he said to the patient at the 6-week follow-up, "You fixed my cystocele, you fixed my rectocele. But really what I like about what you did is that sex is great, and it wasn't great before." And if that was all that had happened, we wouldn't be here today. Because she told her friend, "Hey, listen, you got to get an anterior and posterior repair. It's great for sex." Totally bypassing the whole clinical side of pelvic organ prolapse. So she presents to Dr. Matlock and says, "Hi, my friend had a procedure by you. I think it's called an anterior and a posterior repair. Can I have one?" And he said, after he examined her, "Well, you don't really have much of anything that I would call prolapse or cystocele or rectocele. But I will do it for you." Now, if that were you in that situation, how many of you would have said, "Sounds like a good idea"? He did it, and the sex got better. And then another woman was informed by these two. And so it spread. And that was the beginning of what we do today. It started with an anterior and a posterior repair, and a friend telling a friend that it's great for sex. And Dr. Matlock, at the time, was going for an MBA. And as part of his training in his MBA, they said, "Why don't you develop a project and work on it?" So he came out with a whole line of procedures called laser vaginal rejuvenation for vaginoplasty. Vaginoplasty, labiaplasty, labia majoroplasty, hymenoplasty, and the G-shot. He came out with all of this over 25 years ago, all in one shot. So from nothing to a full menu of cosmetic gynecology, minus the non-surgical, minus the energy-based devices, was happening in the late 1990s. So he started a training institute, and this spread all over the world. And so in 1999, we had surgery and we had the G-shot. That was the entirety of what you can do in cosmetic gynecology. And there weren't that many people doing it. There was no internet, there was no Google, there was no app, there was no sharing. It was all word of mouth, starting in California. And the doctors that got into this were people comfortable working in the vagina and people comfortable doing aesthetic surgery. So you had a bunch of plastics and you had a bunch of gynecologists. Now the gynecologist knows the female anatomy, knows the hormonal milieu of the patients, and the plastic knows all about aesthetics and counseling people about the expectations and all. So if you went to either of these two, you were getting solid knowledge relevant to the vagina. And then 15 years ago, a guy that we trained in liposuction bought a laser because he went to a liposuction meeting in Buenos Aires, and Dr. Guillermo Blugerman was showing him a laser, and he said, "You got to get a laser. You can use it for liposuction." And he said, "Well, I could probably use it for genital warts as well." So he got his laser, which was a CO2 laser, and he started treating what the gynecologist traditionally treats. You do laser cone biopsy, you do laser ablation of condylomata, and he would do the intravaginal ablations of these conditions. And his menopausal patients started saying, "You know, doc, I felt dry in there, but I don't feel quite so dry anymore." So he got together with DECA. DECA is a company that came out with the Mona Lisa laser. In the United States, it's marketed by Cynosure, but it's a DECA product all the way through. And they had the lasers that you use for skin. Now, the difference is that the vaginal canal, you want to fire it at a right angle, not straight on. So they had to add an extra mirror to the laser. So between his recommendations and the company's engineers, they came up with the prototype Mona Lisa. So now we had non-surgical devices. We had the G-shot, and we had surgery. The size of the surgical market did not go down at this time because there was still no good treatment to replace a labiaplasty or a vaginoplasty, which in my opinion there still is not. But it expanded the market. In regular aesthetics, like say in facial plastics, it's 5 to 1. There's 5 times as many cases, 5 times as many things to do to a face non-surgically as there is surgically. You can combine them, but if you run a practice, you'll find that that spa makes a lot more volume and a lot more consistency than surgery does. So now the market expanded. And what's the problem with the device? Anybody can buy one. People that don't know the vagina. People that don't know aesthetic expectations. People that don't know much more than that it has an on and off button and you can just fire the thing. So the derms got on board because they're very comfortable with lasers. Also, many of them are into aesthetics. So yeah, they're harmless getting into this field until they start to tackle the vaginal canal. Because what do they know about that vaginal canal? Not much. They know about the skin of the vaginal canal. But that's like saying you know what the tiles are on a roof. You don't know about the house. You just know the surface, which is hardly the problem for many of these people. So the field of cosmetic gynecology started to expand beyond the initial two specialties. So this was the mid-2010s. You had the aesthetic show and a couple of other major aesthetic shows featuring these procedures. Industry saw a huge market expansion because they said, all right, we have lasers, we have radio frequency, we have all these devices, we have these platforms, and now we can add a vaginal probe. And then 13 years ago, our friend in the back, Dr. Charles Runnels, who was making his name with platelet-rich plasma with the vampire facelift, started developing products for the vagina and for the penis. He came out with the O-shot. So this was the birth of the Biologics in cosmetic gynecology. So now we had Biologics, devices, the G-shot, and surgery. The surgical market did not get any bigger. Thank you. The pie got bigger. More women could dip into this. Anybody could get into the biologics. And a lot of people were too cheap to take the training in these things. So now you have untrained people flying around with needles, lasers, and anything else. And that creates problems. Lots of problems. So now you have a diffusion. When you have a league like the NFL or the NBA or Major League Baseball, or even soccer, and you expand with more teams, you have to take the players and distribute them. So that means that the level of performance is lower initially. So you have good ones and you have bad ones. More good ones, many more bad ones. So as you have untrained people, poorly trained people getting poor results, the procedure gets the bad name rather than the skill of the person operating on it. And I think everybody in this room has been preaching from a soapbox at one point or another about the need for education and the need for untrained people to get training or just stop offering these procedures because they do a lot of damage. So at the present day, we have qualified people, unqualified people, unqualified non-physicians, all over the place. And what happens with this, at some point in time, the regulators step in and they start to make it difficult for the ones doing good work to continue doing good work without the mountain of hassles. Now, there are 4 players in cosmetic gynecology. Okay, there's the cosmetic GYN, knowledge and skill base. There's the general aesthetics, knowledge and skill base. There is the healthy aging, knowledge and skill base. And there's the classical gynecology, knowledge and skill base. And when these converge, what we have is the people in this room. People that are conversant in all of these things, specialize and gravitate to one or the other of these domains, but they know about the others because they come to meetings like this to understand, okay? I'm not a labiaplasty doctor, but now I know why a patient may have pain with labiaplasty. I may know why a patient who has a filler put in the vagina is behaving a certain way, why edema is presenting a certain way. They're knowledgeable, so they're not going to recommend things that don't make sense. And that's when you have synergy. You have, the best of multiple knowledge bases, creating better things, pushing the field forward, being watched the whole time by knowledgeable people. And that's how this grows. But we also have confusion because outside this room, there are 10 times as many people bought a machine, bought a product, learned something off of TikTok or something like that. And they market it to the patient based on the 5-star expectations that primarily come from marketing, either from marketing that somebody hires or a company just eager to sell a product. And then you have the patient says, if I have this procedure, I'm getting 5-star results. And then they get the 1-star result. And then everybody's miserable. So the first thing that anybody in aesthetics needs to learn is that you need to manage expectations. Because if I tell you you're going to get a 3-star result because you're just not the right person for this procedure, and you get a 3-star result, I gave you what I told you were going to get. And if you get a 4-star result, you exceeded the expectation, you will be happy. But if I tell you you're a 5 and I get a 2, I don't care, what talking happens, she's miserable, and you fell short of the expectation. You have to unbrainwash the people who have brainwashed themselves, just hoping that they are the case for the 5-star result, okay? A lot of people want liposuction when they need a tummy tuck. Why? Because it's cheaper, it has a faster recovery. I said, that's not how you pick a procedure. The anatomy dictates what you do. The condition dictates the options. It also sets the expectation. What can you expect from each option? So you have to brainwash the patient because they're coming in with these expectations. They've already done their quote-unquote research. But it's not research. They just convince themselves that these things are that great. So rather than say, okay, I am a provider of a Vaser or a Renuvion or a J-plasma, maybe you are. Maybe that's what brings the patient to the door. But when the patient comes in, they said, I want this, I want that. I said, show me what you want me to fix, and I'll tell you what's broken and what's required to fix it and what will not work. Because I don't want to waste your time, your money, my time, my money, and I don't want to set you up for a 2-star outcome if you're the wrong patient. So you have to identify the problem. A patient who comes in for a vaginoplasty doesn't want a vaginoplasty. She wanted better sex. She just doesn't know how to get there. She might just need estrogen, testosterone, Kegels. So just because her friend got good results doesn't mean that she's going to get good results with the same exact procedure, because she's not the same exact person. All right, the internet rock star, might be great at getting clicks and likes, but that doesn't mean they're necessarily the best person to do a procedure. All right? Because if Celine Dion starts offering vaginal rejuvenation, she's going to get a lot of inquiries. But I wouldn't let her anywhere near even my dog's vagina. So you have to remember, the doctor who's doing this procedure, you should know to ask, how many of these procedures have you done? How well have you done them, and who said so? Then, you buy the nice skis, you buy the nice golf clubs. You're not a skier and you're not a golfer just by buying the equipment. So buying the laser doesn't make you a laser expert. It makes you armed and dangerous. You have a device that can burn through anything. And if you don't know what you're doing, you're going to burn through things that didn't need to be burned and create massive problems. The industry is going to show you how to turn the machine on and off, how to use it, how to drive the Ferrari. But they're not going to tell you that it's not good to drive it in the snow or off-road. It wasn't designed for that. They're just going to tell you how to use it, but not when not to use it. So what this means is you buy the laser, you need to buy laser education right away. Maybe you should have bought it before and you'll pick a better laser. Triple board certified. How often do you hear that in advertising? Sounds great, right? Show me a single board that rates labiaplasty knowledge. None. Not one. No real board does that because they're not here. There's not a single ACOG academic that comes to these meetings. So how can they know enough to criticize or even to judge or even to say this procedure definitely no good? So I've never seen you here. I've never seen you see a procedure. So I don't care what degree you have, At some point, you have to have knowledge in what you're talking about rather than just opinion. Expertise in other things doesn't mean you have expertise in cosmetic gene. I'm just pounding this into the ground because a lot of people think, I'm a urogynecologist. That means I can do a labiaplasty. No, it doesn't. They don't teach that in urogynecology fellowships. And the people who do them might do 2 a year for the most extreme case, and then they still do it wrong. They think if Kelly clamp cut it off and say you're cured. You're not cured. You're budged. So the urogynecologist per se is not an expert in cosmetic. They may become one. There are many that are, but right out of urogynecology fellowship, Miklos and Moore will tell you they had to go learn it because it wasn't taught there. Plastics, same thing. All right, plastic surgery programs expose you to a wide variety of procedures, but do you think that a private practice cash-paying patient is going to let some resident work on her vagina? No, it's a big no. It's a big no. And the nuances of this stuff, definitely, it's going to be private practice, and it's going to be something that needs additional training beyond what you normally get in your program. Urology, same thing. Same thing. Then you have the doctor that's all about the cash. They get greedy, they start doing all kinds of things that make money, but not necessarily indicated for the particular patient. So eventually that ends poorly, because the poor results, eventually the money will go elsewhere. So don't be greedy. I think the best advice is be a problem solver. Don't be a seller of procedure X, Y, or Z. See the patient who wants the tummy tuck as a patient who wants a flat tummy. See the patient who wants liposculpture as a patient who wants a more defined waistline. That wants a breast augmentation, wants a nicer cleavage. Maybe it's a breast implant, maybe it's a lift, maybe it's something else. But what she wants is a result, not a procedure. She just wants you to help her get the result. But if she's hooked on a procedure because her best friend had it, you have to unbrainwash it. All right. Just because a procedure is cheap doesn't mean you can just do it with soft indications. Same thing goes for risk. Same thing goes for speed. Okay. Let's just start with the Mona Lisa. You got me. You got me. You got me. All right. I promise to give you extra minutes. All right. So what you should know is that you have to understand your problems, identify your solutions, be educated in your solutions, and use that knowledge to design a strategy. All right. Bring together all of the knowledge bases, and you're going to have a lot of happy patients. Thank you very much.